Welcome back. This is Amy Reeb, and we are jumping into the second half of our lecture. We'll now talk about Chapter 55, Drugs Acting on the Lower Respiratory Tract. Let's get started. Here are the objectives for this chapter. I think we should be able to meet all of them. I have to laugh because I don't think right now, at least not this week, I am the best role model of time effectiveness. It is now 1:48 in the morning and I'm getting started on this chapter. The funny thing is that I think I could probably host this lecture live using Blackboard Ultra Collaborate because half of you are probably still awake in third track anyway. Since you are currently studying pulmonary pathophysiology in Med-Surg 2 right now, you are familiar with changes in the airway with COPD. COPD is just a term used to describe a chronic obstructive pulmonary disease, be it either emphysema or chronic bronchitis. With emphysema, we have air trapping in the alveoli. The alveoli no longer have maintained their shape. They kind of become oversized and floppy, kind of like an overinflated balloon. Moving over to our chronic bronchitis, this is where we have chronic inflammation as well as increased number of mucus glands, which then produce increased amounts of mucus. So we have excess mucus causing a chronic, usually productive cough. Usually much worse in the morning. As you know, COPD is chronic, progressive, and for the most part largely irreversible disorder that is characterized by airflow restriction and inflammation. We have our characteristic signs and symptoms including excessive sputum production, chronic cough, wheezing, dyspnea. Cause is usually secondary to cigarette smoking. Among the individuals with COPD, the processes can vary significantly, but for the most part we'll get air being trapped in the lower respiratory tract, either due to that chronic inflammation and secretions or because of the deterioration of the elasticity of the alveoli and allowing themselves to collapse upon themselves. We may see the alveoli degenerate and fuse together. The big picture is that gas exchange is significantly impaired. Again, I'm sure Dr. Sabio's already covered this. Prevention treatment for COPD. Obviously, reduce the exposure to environmental irritants, stop smoking, filter allergens from the air. Again, avoid exposure to known irritants and allergens. We want to, pharmacotherapy-wise, we want to go ahead and open up the conducting airways through muscular bronchodilation. We also want to decrease the effects of inflammation on the airway lining. Ideally, we're hoping to relieve symptoms and avoid complications. Again, for the most part, this is largely irreversible, though. So one of the mainstays of therapy for COPD and asthma are going to be our bronchodilators. We'll start with the xanthines, but I have to be honest, we do not use these very much anymore unless they're in a miserable case study. What they do is they have a direct effect on the smooth muscles of the respiratory tract, both in the bronchi and in the blood vessels. They're found in naturally occurring sources, and as your book says, they were once the primary choices for treating asthma, COPD, bronchospasm. However, they're not used quite as much anymore because they really did have a narrow therapeutic index. They also interact with a lot of other drugs that you probably figured out during your case study. and we have better drugs now. These are rapidly absorbed from the GI tract, metabolized in the liver, excreted in the urine. So the xanthines, or other books call it methylxanthine class, are contraindicated with patients who have significant GI problems, coronary artery disease, respiratory dysfunction. Hey, isn't that the reason we're taking it? Renal or hepatic disease, ETOHers, and hyperthyroidism, simply because they can be made worse by the systemic effects of the medications in this class. The adverse effects are really related to that narrow therapeutic index. So it's related to the levels that we have in the blood. We can see GI upset, anorexia, nausea, vomiting, irritability at some of our higher thresholds. When we're starting to see plasma levels greater than 30 micrograms per milliliter, we can see severe dysrhythmias, such as, VFib. We could see seizure, brain damage, and even death. Typically, we want to keep plasma levels below 20 to avoid toxic effects. Drug-to-drug interactions, well, there's many drugs that interact with the xanthines, as I'm sure a lot of you figured out during that case study. That could include tobacco. Yikes. Nicotine increases the metabolism. So for our smokers, you need to significantly increase the amount of theophylline that the patient is receiving. Our H2 blockers, particularly cimetidine, can interact, as can, I'm sure you all figured out, our fluoroquinolone antibiotics will interact with theophylline. For those of you that might not have gotten that, perhaps I should allow a second attempt of the case study. Alright, so our prototype that the book uses is going to be the aminophylline. I think theophyline's more often seen. And by the way, absolutely thank you so much for the pictures. I think these are Josh's dogs. Love the dogs. Adorable. Again, our xanthines will directly relax that bronchial smooth muscle. So we're getting bronchodilation, increasing vital capacity, decreasing the histamine response. Important to note that our half-life can be closer to 15 hours for a non-smoker versus it can be about a third of that time for a smoker. So if a patient takes up or stops smoking, we need to adjust levels significantly. Again, adverse effects include irritability, restlessness, dizziness, palpitations. We could see life-threatening dysrhythmias, including VFib. We could see anorexia, proteinuria, respiratory arrest, no pressure, fever, and or flushing. Our book focuses on the sympathomimetics as a whole. And as you know, those are drugs that mimic the effects of stimulating the sympathetic nervous system. I think really when we're talking about COPD and asthma, let's really focus it down and narrow in on the beta-2 adrenergic agonists. That's what most other textbooks do. We kind of talked about that back during week 2. So mechanism of action for our beta-2 adrenergic agonists, they activate the beta-2 receptors in the smooth muscle of the lung, which then promote bronchodilation and relieve our bronchospasm. They also have a limited role in suppressing the histamine release in the lung and increasing the ciliary motility. So our beta-2 agonists use in asthma and COPD, we're going to break it down into 2 different categories. First, we have our inhaled short-acting beta-2 agonists, SABA for short-acting beta-2 agonists. These are utilized PRN to abort an ongoing asthma attack. We can also utilize them prior to exercise to prevent a bronchospasm. Hospital patients undergoing a severe acute attack, we will use a nebulizer. Short-acting beta agonist is our traditional treatment of choice. I'm sure most of you have seen that in the clinicals. Of note, if we utilize delivery with a metered dose inhaler in the outpatient setting, that may be equally effective. Maybe. I still think perhaps a nebulizer works a little bit better, especially with our pediatric patients. Continuing on with our beta-2 agonists used in asthma and COPD, now let's talk about the inhaled long-acting beta-2 agonists. Sometimes you'll hear this referred to as a LABA. This is a maintenance medication. It is used for long-term control in patients who experience frequent attacks. Again, the dosing is on a fixed schedule. It is not PRN. Usually, a lot of these are twice a day, though we do have one new one that's out that's just once a day. It is effective in treating stable COPD. However, we do have a black box warning because it can increase risk of bronchospasm. If we are using it to treat asthma, they must always be combined with an inhaled corticosteroid. The use of a long-acting beta agonist just by itself is contraindicated in asthma management. Adverse effects of our bronchodilators, our beta-2 adrenergic agonists, really come from stimulation of the sympathetic nervous system. We might see some CNS stimulation. We could potentially see tachycardia is really kind of common. We might see GI upset, increased risk of cardiac dysrhythmias, hypertension. We could get a rebound bronchospasm, tremor for sure, sweating, pallor, flushing. We do not want to use in the case of acute MI. Again, adrenergic agonists are increasing the sympathetic response, again adding more pressure to the heart. Drug-to-drug interactions, I'm not sure that general anesthetic, sure, I'm not sure they necessarily need to know that though. Okay, we are up to slide 15. I changed our prototype drug over to albuterol. That just makes the most sense to me. When we're talking about drugs acting on the respiratory system, let's really look more at our inhaled beta agonist. For albuterol, onset usually is within 5 to 15 minutes of inhalation. If we're old school and use albuterol PO, it's going to take longer, 30 to 45 minutes. Peak of action is really going to occur within half an hour all the way through 2 hours. Duration could be anywhere from 2 to 6 hours. It's important to note that if you have a patient that needs to utilize both a short-acting albuterol and a long-acting beta agonist, it's most important to have them go ahead and use their short-acting inhaler first. Wait about 5 minutes until the short-acting beta agonist has kicked in, opened up the airways, and then utilize your maintenance inhaler, your long-acting beta agonist or long-acting beta agonist combo. In doing so, more medication is going to reach the intended target and you're going to maximize your therapeutic response. Another true-false question, just to make sure you didn't fall asleep. Adverse effects are related to theophylline levels in the blood. and can include brain damage. That kind of makes me want to hide under the bed too. The correct answer is true. Adverse effects related to theophylline levels in the blood can range from GI upset, nausea, irritability, all the way through to tachycardia, seizure, brain damage, and or death. Before I move on much further, let me just point out, especially in this chapter and the previous chapter, please be sure that you are reading the blue boxes in our books that highlight nursing considerations, especially the implementation. Also make sure that you know the different mechanisms of administering some of these inhaled medications. I also have a whole bunch of different inhalers from my office that we were going to throw out that are currently sitting in my trunk that I was going to pass out to you guys on Friday, just to let you see how some of these look like, how some of these work, the difference between a dry powder inhaler with our standard metered dose inhaler. Let's move on to anticholinergics. Seeing anticholinergics kind of feels like an old friend now. I feel like we've seen anticholinergics in a whole bunch of different applications. Really, for patients who cannot tolerate the sympathetic effects that we see with our beta agonists, or who need additional support, we will go ahead and break out anticholinergics. Again, remember that's blocking the parasympathetic nervous system, blocking the vagal-mediated reflexes. It's antagonizing the action of our acetylcholine. Again, we can utilize it with treatment of bronchospasm associated with COPD. When we utilize our anticholinergics, typically onset of action is about 15 minutes after inhalation, peaks after 1 to 2 hours, and will last usually 3 to 4. So again, these are going to improve lung function. It's blocking the muscarinic receptors, the acetylcholine receptors, in the bronchi, reducing bronchoconstriction. Again, therapeutic effects will begin quite rapidly, but sometimes until we see max effect, it might take a few of these doses, especially when we're thinking of tiotropium. We need to use caution with any condition that could be aggravated by anticholinergic effects of the drug. Adverse effects include anticholinergic effects such as dizziness, headache, fatigue, nervousness, dry mouth, sore throat, palpitations, urinary retention. Have to watch for glaucoma as well. And I love the picture of these two friends who are obviously ready for Halloween. Speaking of which, I am going to not see you guys before Halloween, so I hope it's wonderful. So our prototype for our anticholinergic is going to be our ipratropium, which we use for management of bronchospasm associated with COPD. Nasally, we could use it for allergic rhinitis. Again, it has its anticholinergic properties, which you're familiar with. When we inhale it, onset 15 minutes, peak 1 to 2 hours, lasts 3 to 4, and adverse effects includes anything that we think of with anticholinergic effects. So steroids are the most potent natural anti-inflammatory drugs. Our inhaled steroids are truly the drug of choice for long-term prophylaxis of asthma. Our inhaled steroids, other texts will call it inhaled corticosteroids. You might see it abbreviated ICS. Must be taken daily. Usually systemic side effects are very rarely observed. We will use them in children. The only thing that we do want to make sure is that growth is still okay. If we do oral steroids really are used for short-term therapy of a severe acute asthma, typically we want to limit that therapy to less than 10 days. Again, going back to our inhaled corticosteroids, the indication is prevention and treatment of asthma and to treat chronic steroid-dependent bronchial asthma. Keep in mind this is maintenance. This is not your short-acting beta agonist. This is not going to be used to terminate an asthma attack in progress. Pharmacokinetically, it's well absorbed from the respiratory tract, metabolized by natural systems in liver, excreted in urine. Look, Barry doesn't look happy. He knows that I just got ahead of myself. So as I said, contraindications, it is not used for an emergency during an acute attack or status asthmaticus. That's really when we need to break out our short-acting beta agonist. And by the way, the background story on Barry from Rebecca Banks, he was first adopted, and when the shelter rescued him, his fur was badly knotted and covered in burrs. They ended up shaving him and gave him the name of Burry. So this is when he was first adopted, and he's obviously not thrilled about his haircut there. So again, our inhaled corticosteroids reduce inflammation. Adverse effects include some people will have sore throat, hoarseness, coughing, dry mouth. We have to watch out for oropharyngeal candidias, yeast infection. Nursing intervention is we need to make sure that the patients rinse their mouth and spit after use of their inhaled corticosteroid. Here's the prototype inhaled corticosteroids summary. They used budesonide. Next, let's move on to our leukotriene blockers, or leukotriene receptor agonists. These selectively and competitively block the receptors for the production of leukotrienes. Our body tends to produce leukotrienes more at night, so ideally these medications should be taken. They're taken once daily, but ideally in the evening. Indicated for prophylaxis and chronic treatment of bronchial asthma in adults and in kiddos younger than 12. Our leukotrienes, by the way, are involved in allergic and asthmatic reactions, and our leukotriene inhibitors or blockers are then trying to help in reducing the inflammatory component of asthma. It's an oral medication that we will use when persistent asthma is not well controlled with other medications. Pharmacokinetically, it is absorbed from the GI tract, extensively metabolized in the liver, and primarily excreted in the feces. We need to be careful with hepatic impairment for sure, maybe consider renal. We want to be cautious with pregnancy and lactation. I saved this pet picture towards the end because I figured we would really need it. Really appreciate the student who replied with, "Good evening. I don't have a pet, but this is my boyfriend. I feed him, take him on walks, and rub his head. So, it's close to the real thing." Moving back to our leukotriene blockers, adverse effects include headache, dizziness, myalgia, nausea, diarrhea, abdominal pain. I don't usually see those, truth be told. Elevated liver enzymes we need to watch for. Vomiting, generalized pain. Don't usually see that. One rare that I have seen, maybe only twice, is mood changes as well. Drug-to-drug interactions are listed there. Again, I think that's something that you're going to look up and not something that I'm going to put on a test or quiz. More often, I prescribe montelukast. Our textbook utilizes a different prototype summary. which is of course much harder to pronounce. I'm guessing Zafirlukast. Again, this is going to be a medication that would be better if you administered in the evening. Exact same adverse effects that we had spoken about previously. Also important to note with our leukotriene blockers, these aren't going to work as rapidly as our histamine blockers. So our antihistamines like Benadryl, where you take it and you will feel a difference. This one might take a few days. Reassure your patients that it will help, but it's just going to take a few days until it kicks in. Okay, stepping completely away from asthma and COPD, let's talk a little bit about lung surfactants. You guys are in OB. Shoot, you probably know more about this than I do because I've never administered it. What does it do? It replaces the surfactant that is missing in the lungs of our neonates with respiratory distress syndrome. These medications are administered by direct intratracheal instillation. Again, it's reserved for rescue therapy of RDS. What it does is it lowers the surface tension forces that cause the alveolar collapse, and then it rapidly improves the oxygenation as well as the lung compliance. Treatment, according to one reference that I have, decreases neonatal mortality by up to 33%. So it begins to immediately act on instillation into the trachea. It's metabolized directly in the lungs. I can see that Bing and Jocelyn are thrilled that we're coming up to the end here. This is an emergency drug. There are no contraindications to it being given. Note that the effects of a single dose can be transient and repeat dosing may be needed. Adverse effects, these aren't completely benign. Patent ductus arteriosus, hypotension, intraventricular hemorrhage, pneumo, pulmonary air leak, elevated bili, and or sepsis. Clinical trials have shown that utilizing the lung surfactant does produce far greater outcome with respect to mortality than just simply intubating and providing supplemental oxygen to a neonate. Prototype, here you go. Adverse effects, pretty much as we had spoken about. And I love the beautiful husky. Not sure that I love the snow. Question, in case you weren't paying attention a couple slides ago, what is the contraindication to using lung surfactants? Answer, no contraindication because it is an emergency drug in a newborn. You can go ahead and read the lifespan considerations on your own on page 924. Okay, so we're probably up to 30 to 35 minutes of recording now. We are almost done. Let's make it through our 4 Kahoot questions, which aren't on Kahoot. Question 1. Patient with asthma is prescribed albuterol 3 times a day. You should teach the patient to do what? With albuterol, are they going to rinse their mouth after taking the prescribed dose? Are they going to take an extra dose if breathing is compromised? Do they need to wait a minute between puffs from the inhaler, or do they need to take adequate amounts of calcium and vitamin D? Okay, pause if you don't have the answer yet. Correct answer is C. Patients should be taught to wait at least 1 minute between puffs. Extra doses should not be taken unless prescribed by the healthcare provider. It's our inhaled corticosteroid or glucocorticoid inhalation that requires oral rinses to prevent the development of oropharyngeal candiditis, yeast infection, or thrush. Patients should take adequate amounts of calcium and vitamin D with glucocorticoid therapy? Question 2. Your patient with asthma is prescribed trisimilone acetonide. LONE, think steroid, okay? What should you do? Are you going to A, take the patient pulse before administering the medication, B, teach the patient to use a spacer to prevent a fungal infection, C, instruct the patient to use this drug to treat an acute asthma attack, or D, encourage the patient to avoid weight-bearing activity? Where's the cahoots music when you need it? Answer is going to be B. So it is an inhaled glucocorticoid, an inhaled corticosteroid. Spacers disperse the medication into the lungs, leaving less in the oropharyngeal mucosa. So as a result, this decreases the incidence of the fungal infection. A is incorrect. It's our beta adrenergic agonists that cause tachycardia, and they are also used to abort acute attacks. And patients taking glucocorticoids or inhaled corticosteroids should engage in weight-bearing activities to prevent, unlikely, but prevent osteoporosis. Again, this is a maintenance drug. This is not utilized to treat an acute attack. Next question, which information should you include when teaching a patient about inhaled glucocorticoids? Should you tell them that they have many significant adverse effects, that the principal side effects of inhaled glucocorticoids include hypertension and weight gain? C, use of a spacer can minimize side effects, or D, patients should rinse the mouth and gargle before administering inhaled glucocorticoids? This one seems too easy, especially after the last one. Correct answer is C. The inhaled glucocorticoids, or inhaled corticosteroids, are generally very safe. Principal side effects are risk of oral pharyngeal candiditis, maybe some dysphonia, which can be minimized typically using a spacer device during administration, and rinsing the mouth and or gargling after use. Last one. Which of the following is not a serious adverse effect of long-term oral steroid therapy? Is it going to be A, adrenal suppression, B, osteoporosis, C, hypoglycemia, or D, peptic ulcer disease? Correct answer is C. Serious side effects of long-term use of steroid therapy, oral steroid therapy, includes adrenal suppression, osteoporosis, hyperglycemia, peptic ulcer disease, and again with oral steroids we could have some growth suppression of our pediatric patients. And that is it for the end of chapter 55. Thanks for hanging in there all the way through this lecture with me. The sun is not yet rising for me. I hope it isn't for you either. Again, I greatly appreciate your patience and understanding this week. Please do reach out to me if there is anything that I can do to help your learning. I am catching up and I will be able to get back to you in a timely fashion. Thanks. Have a good one.